So I've been in the London Ambulance Service since the end of November last year, beginning of December, and the brief that I was given was to look at how we could introduce other healthcare professionals and new ways of working into the service. So hopefully as we go through the presentation this afternoon, that's one of the things that I will try and weave into the work. So what I want to talk about in the session this afternoon is a little bit about how we work and what we do. And I know that sounds really daft and that you'll know that we answer calls at 999. But when we talk about some of the calls we do get, you might understand why I'm going back to talking about what we do and what we don't do. And then I've brought along some case studies for us to talk about, and I'd be really interested in your thoughts about the case studies, and these are genuine calls that we've had from patients. So a little bit about us as a service. We are officially the busiest service in the world. I'm led to believe that Rio de Janeiro have nearly as many calls a year as we do, but the majority of their calls are for gunshot victims, whereas the majority of our calls are not. In fact, that's probably the least number of calls that we have. But on average, we have about 5,000 calls a day that all come into our two call centres, one at Waterloo and one at Bow. We serve a massive population because we cover all 32 CCGs within the M25 boundaries. And there are parts of the M25 that we actually do attend calls at as well, which we share with either East of England or South Central ambulance services. What makes us unique compared to the other ambulance services around the country is clearly that as we have Parliament here and we have the royal family here, that brings some different and interesting issues, especially when you get a call from the Buckingham Palace and everybody goes very quiet in the call centre and tries to work out what the call is for. We have to deal with 5 police forces, so not only the Metropolitan Police but the Transport Police and so on and so forth. We have 3 airports that we deal with. Clearly, in light of some of the issues that have been going on in other capital cities around the world, particularly most notably Paris recently, the ever increasing threat of terrorism is there, and our response to that is a daily requirement for us. And very interestingly, I asked the daft question why we have additional resourcing in our service in July and August, and of course it's to meet the needs of the tourists who it appears are very enabled to cross our roads, and our number of road traffic accidents in July and August seems to be greater than any other time of the year. So an average day for us, as I say, is about 5,000 calls, which is increasing between about 6 and 7% on an annual basis. That equates into just under 3,000 patients, because you can imagine if there is a road traffic accident, we get a frequent number of calls about the same thing. So not all of the calls equate to the number of patients. And of those, you can see the majority of patients are conveyed to hospital. And one of the things that we need and want to talk about this afternoon is whether that's appropriate, that we are conveying all of those patients. Just over about 1,200 are our Category A calls, and I'll talk a little bit more about that in a moment. And our Category C calls, which are our less acute calls, are the majority of our calls. And again, I'll talk a little bit more about that in a moment. But one of the things that we have seen a really huge rise in, and one of the remits and briefs that I have and Bryony, my deputy, has, is around telephone advice. So we are giving more and more telephone advice, and that is on the 999 call. That's aside from our 111 service. So we do a lot more hear and treat, and we're increasing that, and we're growing that part of our business. So in terms of how does it work, and I know this sounds really basic, but the call doesn't come in to us first of all. It goes to a BT operator who then determine which emergency service the call needs to go to. And if you think about it, you all hear about people talking about the 8-minute response time that we have to respond to a Category A or Red 1 patient. That includes the time it takes us to answer the call, process the call, and be dispatching the vehicle. So we have a very, very short period of time in which to make an assessment about the patient. Our call centres are operated completely by non-clinicians, so any information that is given to them is then triaged using our triage system. So the people who answer the telephone are unable to answer clinical questions, and they do get a lot of clinical questions, but they are unable to do that. And having sat in the call centre, I think it would actually be a disadvantage if we had people with clinical knowledge answering the calls, because actually you wouldn't get to the right dispatch disposition. Then one of two things happens at that point in time. If the person triggers a red 1 or a category A response, we have automated dispatch, and so the automated dispatch will start even while the call is still in progress. So even though we're getting more and more information about the patient, the dispatch process will start. If it doesn't meet that threshold, then the dispatch is passed to another part of the room where they dispatch the appropriate vehicle to the patient. And as the call is ending, our call handlers have several end-off messages. So if the person is bleeding, they'll give them some basic first aid information about that. If the person's lying somewhere where they may be in a roadway or something, they'll give them advice about maintaining safety, but they'll give that kind of advice. There are several occasions, two that particularly spring to my mind, where the call handler stays on the call for the whole duration until the ambulance or the rapid response vehicle arrives. And that's in the case of childbirth, where it's very, very interesting to hear somebody giving advice about childbirth over the telephone when they can't see anything that's going on. And often the person who's they're giving the advice to has no clue either. And all you can hear in the background is all sorts of screaming and shouting going on, and we do any child who shows capacity, we will talk them through that process. We don't ask about their age. If they show capacity and aptitude, we will talk them through that process. And then the second occasion on which the call handlers will stay on the call until the crew arrive on scene is in the case of a cardiac arrest, where again our call handlers are trained to give CPR advice, basic CPR over the telephone. And I have to say that having listened to it, it's just the most amazing thing to listen to, and the way in which they interact with patients is absolutely phenomenal. So as I say, all this goes on, and we literally have, bearing in mind we only have 8 minutes altogether, this process is a very, very quick process. So how do we triage the calls? Well, we have our red 1 triage calls, which is the 8-minute response, which is people who are in cardiac arrest or unconscious or have ineffective breathing. And our target is to really reach 75% of those within 8 minutes. We then have our red 2 responses, which is where people have difficulty in breathing, but they are able to maintain some airway, and they're able to have some kind of conversation or some kind of sentences. And we have 95% of those calls we arrive at within 19 minutes. We then go into our 20 and 30 minute response rates, and then our later response rates, which are our category C responses. C1 is our 20-minute response, and an example of the kind of patients that would fit into that would be somebody having a sickle cell crisis. Our next category is a category 2, C2, which is somebody who's fallen and they have sustained an injury. That is an injury where there's a deformity, for example. Our third category is then around a number of people who fall into this would be people, gynae, miscarriages, PV bleeding and those kind of things. And then our category 4 responses, which are ever increasing, is people such as elderly fallers who have are still on the floor but have no apparent injury. So what you can see from the two graphs here is the top one is really demonstrating that our performance has not been where we would want it to be, and that is in light of the number of calls that we're getting, the number of people that are expecting a greater response, but also, as you will all know from your work, the sheer volume of people who are accessing emergency care services as their primary source of care. So in bygone bygone years when people would have gone to their GP or would have gone to the walk-in centre, they're accessing 999 and getting into the emergency pathway as well. And that pattern fits really nicely with the number of attendances at A&E, and you can see there is correlation between those. So the challenges for us really is about performance pressure on the whole system. It was interesting, I was sat in one of the talks earlier and people were talking about out-of-hour services. We don't have out-of-hour services. We operate 24/7, 7 days a week, including the bank holidays, and we have exactly the same staffing on, including our management staff through that period. So I heard people saying, oh, there wouldn't be managers around. We have exactly the same staffing, so there is always a gold officer on duty, and that doesn't matter what day of the week that is or when that is. Clearly in the financial climate, two impacts on us really. One in terms of the services that we're commissioned to provide, two in terms of the services that you're commissioned to provide or are providing or are commissioning for, in terms of the changes that's made. But also the other impact from a financial impact is in terms of austerity and how people are living and how they're leaving it a long time before they're accessing healthcare and some of the changes around that. And what we've realised is that we can't carry on doing the same as we've always done. We need to change, we need to react, we need to work differently. And again, I was in one of the talks earlier and somebody was talking about educating the public. Well, there are loads of messages about educating the public, but it doesn't seem to stop them dialing 999 as their first point of resource, and it doesn't seem to matter what we do, that always continues. But also there is a reasonable reluctance from us as an organisation that we don't want to stop people accessing healthcare, because our greatest concern is that we'd say to somebody, oh, don't dial 999 for this, and then the next time they'd interpret that as I can't call 999, and they wouldn't, and they would be a real emergency. And where we see that the most is in the elderly and the older population, who do seem more reluctant to call, and certainly in terms of the number of ringbacks we get from people who are ringing us back to say how long will it be before the ambulance comes, that tends to be from the younger population as opposed to the elderly population, who we feel are more frail and are in need. And for me, as the Director of Nursing and Quality, all of these changes need to be delivered within a service that maintains safety and is a good experience for patients. Although you'll be pleased to know we don't ask the friends and family test in terms of would you recommend this service, although there is a thought that we should be asking that question. So for us, there is a big case for change here. There is obviously an increasing focus on urgent care as well as emergency care. As I've already alluded to, 10% of our callers are elderly fallers, and that's people who've fallen in their own home, in a care home setting or in a public area. 10% of our calls relate to people with long-term conditions that may be life-limiting or may not be life-limiting, but they have a worsening care. The more care there is that's being given in the community, the more focus there is on people needing to be conveyed from where something has happened to them in the community to another setting, and that is definitely causing us some difficulties. And there also is a shift towards more care being delivered at home, which means that no longer do people necessarily need an emergency vehicle, a double crewed ambulance to turn up, but they're looking for other responses. And when we get onto the case studies, you'll see some of the things that we're being asked to respond to in that regard. So what are we already doing? So one of the things that we have successfully introduced and has been in place for a while is during that period of time when we are dispatching to, and we've got that time at the call centre while we're determining which vehicle to look at, we can transfer some of our patients or some of the healthcare professionals that call into our clinical hub, who can direct people to alternative services if we're aware of them or if we think they're more appropriate. But also at call handling, for a number of patients who fall into Category C and Category 3 calls, we're directing them to phone their local GP or to phone 111 or another service at that point in time. We're doing a lot more assessment and treatment on scene, and we're doing a lot of treatment in homes by the roadside and so on and so forth, with or without referring to local services. And again, if we're very aware of the local services, then we'll certainly refer on to those. We're also asking people to think about, do they really need to go in a blue light ambulance to hospital, or is there another way that they could get to hospital? And it's amazing that when you start asking people that question, the number of people that actually can do that. We do a significant amount of treatment on the way from the area where the incident has occurred to the area where they receive their treatment. And in our call centre, we have an ever-growing clinical hub, which at the moment is staffed predominantly by paramedics, but we've already introduced mental health nurses into that. We've introduced some general nurses who've just started recently, and we're exploring some other healthcare professionals to come into the clinical hub, because the number of people that phone us really just for clinical advice, and actually it's easier for us to give hear and treat advice. One of the other things that we've introduced that's been very successful is with our clinical hub is the callback system. So while people are waiting, particularly if they're in one of the lower C categories, we will call them back, and we have lists that we create of vulnerable patients or patients who we believe need to be called back on a more frequent basis. And we'll call them back and make sure, has their condition changed, has their condition deteriorated, do they need any more support, or have things seemed the same. So I've also talked a little bit about some of the other innovations that we're doing around our mental health nurses. We have got an advert out at the moment because we're doing some work with Coordinate My Care in the Royal Marsden in regard to end of life, because we believe there's a significant amount of work that we could do with end of life patients whose choice of place to die is at home, and at the moment our only option is to convey them. And we manage and run a 111 provider service at Beckenham. So we're doing a lot of work with our Beckenham service to ensure that we are doing what we say we'll do, which is not conveying people. If we've referred somebody to 111, we're trying to then support our 111 service to ensure that people aren't then sent an ambulance, who often don't want an ambulance, they just want advice, or ensuring that we're not dispatching just on the basis of one condition. Calls that I'm going to put up in the next couple of minutes are genuine calls that either myself or Bryony have heard while we've been in the call centre. And what we'd really like to hear from you really is that what do you think we could have done differently with these patients? What do you think are some of the things that are stopping us from doing that differently? And how can you as professionals support us to make a difference? So this is a call that we took one early evening. It was from an elderly lady with metastatic bowel disease. She was at home for palliative care, and that was her choice. Her end of life plan was for her to be at home. Her breathing had become more laboured, and her carers had called 999 for us to convey her. So what do you think we could have done, and what do you think we did do?
If I were you, I would have contacted the palliative care team.
Mm-hmm. Yeah.
It might just be the time.
Yeah.
All the district nurses, see if there's any district nurses involvement, or she had the CMC involved in the
Yeah.
house.
Yeah.
Because then, you don't need to take her to the hospital to go back. And if it's a wish,
I thought I saw somebody else there.
I mean, did this lady have a CMC record?
So I think she did have a CMC record, this lady. So we are now able to access those. Previously, we hadn't been able to access those. So actually what we did was send a first responder to this lady to actually do the assessment in the home, to do exactly as you ladies have both described, which is to see what was the most appropriate place. This lady's choice of place to die was to die at home, and us conveying her was not what she wanted. It certainly wasn't good for her ongoing end of life plan. But it wasn't what the carers wanted, and they weren't really very happy when we sent a first responder who then made a decision for this lady to stay at home. And I think that's about some of the anxieties that they had, and certainly one of the things that we're working on. One of the reasons why we're looking at getting our end-of-life nurses is so that we can make those supportive decisions and support the family, because clearly they'd got to a point where they felt 999 was the option for this lady. Do you think it would have made a difference to what we'd done if this call had been at a different time of the day?
Possibly. I think you were called at sort of 10 to 5, which is when some, I hate to say, people are going home. So I think you probably wouldn't have been called. The carers may have called somebody else out.
So that time period between about 4 o'clock in the afternoon and about 7 o'clock in the evening is one of our busiest times, when we get a huge number of calls, and often it is the kind of worried well. The other thing for us is that at that time of the afternoon we were able to access services, because clearly we don't have access to anything any different to the carers. So actually, had it have been later, we might not have been able to do some of the things that we've done. So in this case, it would have made a difference. So this is another call that we received. Again, it was at 2 o'clock in the afternoon. A 72-year-old gentleman, his catheter was blocked, and they called 999. Everybody cringed.
District nurse.
District nurse.
That's just
That is not a 999 call.
I think though, in defence, is it the carers that call? Is it the carers that call 999? In defence of the carers, what happens is they can't get hold of the district nurses. And so there's an answering machine. And so, I mean, I work for Rapid Response, and we do a lot of work with the LAS, so we know how it goes. But we've often told them to ring us first before you ring. If you can't get hold of the district nurses, don't call 999. So I think in defence of them, is what it is they can't get hold of them, and if they pick up, if there's an answering machine, they will call 999. So
I think the other side to that as well, that sometimes patients with catheters do tend to sit on it for a while, hoping that the problem will resolve, and then it comes to a really very much a crisis for them. So they're in such agony that they will call 999.
There is something about we failed them because we haven't given them good communication lines.
Yes.
And it's the communication lines that are key. It doesn't matter, it's you phone, this is the number to phone. If you can't get this person, then you phone X. And we're not very good at that.
I think though that sometimes when you do say to the patient, don't call 999, or you say to the carer, don't call 999, because of fear, and when they do hear the answer phone, they don't.
But there should be, this is the answer phone number, and this is the number you phone after that. We do put them in houses. We actually physically drew a colour-coded slab and paste them on the wall, but they still call 999. Some
They
patients
certainly do. You see the lady up here.
I think there's also something reputationally as well. Obviously, I have no idea which community teams you're from, but there is a belief amongst people, general public, that if you call 999, they will sort it for you. Because they have to respond. And if you're getting an answer phone and you left a message this morning and it's 6 hours later and the district nurse hasn't called you back, hasn't rung you, we probably would all be guilty of.
So this is one of our most frequent calls we receive, blocked catheters, and actually it's something that paramedics are not trained to deal with at all. So there is a real irony that actually as a paramedic they're not trained to deal with catheters, although we have trained them now, but they're not all trained, and so it's actually an area of where we don't have expertise either. The other really sad thing about this is that we get a large number of calls for blocked catheters from residential and nursing homes. And I'm sorry to say, but we do every day get a large number of those calls, which is really sad. And I'm sure that those of you that work in those areas and commission those services will say, gosh, not for my areas, but it is one of our biggest areas of call.
How do we share that? This is fine. Do you share that back
So we share that information with our lead commissioner, and we share which nursing and residential homes call us on a frequent basis. But one of the things that I've discovered is that we were only sharing that those homes were calling. We weren't sharing the reasons for their calls. So that's one of the pieces of work that I've worked on now, that hopefully in the next few weeks we'll be able to then say, you know, it's this home, they're calling for these reasons, and it's at these times of the day.
I just the comment this morning from the chief executive of the Bromley CIC. Information is absolutely key here, because actually if you could, I know you go back to your lead commissioners, but actually we don't get that as providers necessarily. So, you know, I wouldn't necessarily know if there was a huge problem in one of my boroughs that, you know, district nurses aren't answering the phone or whatever, you know. So I suppose information would be quite helpful, wouldn't it, to transform and change maybe our practice, you know.
Yeah, no, absolutely. Because it was just really interesting as I put this slide up, the number of people whose hands went in their head as if to say, "Oh, I can't believe you get that." I bet you in the time that I've stood here now, we've answered half a dozen calls at this
nature.
nature.
What you need to be aware of as well is district nurses don't see themselves as an emergency service. So when they get a call from 999, they're going to say, "Oh, no, call it," you know. And just the framework, the mindset as well, because what we do is if we're going out on our calls, somebody diverts the phone. So if I'm the coordinator for the day, I divert the phone, so all the calls come to me. But district nurses don't work like that.
No.
So you've got to understand. So when they get calls like this, it's a mindset. They're going to say it's not, you know, automatically they're going to say, "Oh, it's not for them, you know, it's a 999 call." Whereas it's not an emergency, but they should go and attend to it, because the patient often enough is probably on their caseload anyway. So,
Is it not about responsiveness? I mean, yes, the district nursing service isn't emergency, but there does need to be some sort of accepted response time. And I think my scenario in my head was, you called 999 this time because the last time it took 12 hours for somebody to come and change his catheter. The other thing I just want to share with you is that last week I did some work with your colleagues in West London, in Hanwell HQ, about working with the various rapid response services in northwest London, of which there are 6, all of them having different referral criteria, etc., and trying to standardise that so they could hand off more referrals to the rapid response teams rather than emergency departments.
And that's exactly the sort of things that myself and Brian are trying to get our head around, because as you saw at the beginning slide, you know, we work with 32 different boroughs, which just, you know, the number of areas that we deal with and the number of different services is just phenomenal. And our crews aren't always in the area. Then, you know, I could tell you some stories. I think people think that our crews, you know, sit either outside Waterloo and we just shout out the window and say, "Oh, crew 10, it's you to go out now," or they think that the crews sit, you know, on a road in a particular area, and it's just not how it works now. So it's definitely growing work for us. So this is another fairly frequent call, but again, a genuine call that we had at 6 o'clock one Friday evening, a 32-year-old lady who said she felt depressed and she may self-harm. So what do you think we could do?
I don't know what you do, but I sit on a procurement panel for out of hours and 111 at the moment. And certainly you may have a different answer, folk here may, but one of the problems that we have is there is a problem with district nurses with variability, but also handing off appropriately to someone from the mental health team with this thing. And I don't know about from your point of view, but certainly when we're looking at the service, it's a big gap at the moment. Yeah, no, that's a comment, not an answer.
Yeah, no.
In our team, what we would do is we would go and see this lady, and obviously if we can refer to the crisis team, mental health crisis team, which is very difficult, because often enough they finish at 5, we finish at 7, so, but because it's a call that's come into us, we would go out and see her and see what we can do, but you know, and that's what we would do and see what we can put in place. But
These are some of the most difficult calls that we deal with because there is a massive gap here. So one of the things we were talking about last week in the office is the fact that the police no longer do welfare checks. So if somebody has phoned up or they've gone to see a client and they can't get in, the police no longer will just go round and routinely do a welfare check. So then that comes to us, and we go out, and then we can't get in any easier than anybody else can get in. We don't have magic keys like Santa. We get a lot of people who phone again. You can see by the time it was 6 o'clock on a Friday evening, this was somebody who'd clearly got more poorly as the week had gone on and had eventually got to that stage where they phoned at that time of the evening. So our ability to access services at that time of night gets more and more difficult. And the other real difficult thing for us with patients with mental health difficulties is often they don't want to get off the telephone. So actually what our call handlers find is they're not clinical, as I described at the beginning, and they've got somebody who's expressing thoughts of self-harm to a non-clinician. And unlike, delivering a baby or giving resuscitation, there's very little that our call handlers can do. So one of the reasons why we've introduced our mental health nurses into the clinical hub is to take these calls and to deal with these people. And one of the things that we're working with a number of providers is to access, if people are already known to services, so we can try and access their care plans that they already have. So we're working with some of the big providers at the moment to look at how we can access their Rio services and things so that we can do that. But this is a really unmet need in terms of accessibility of service, but a huge number of calls, and a number of our frequent callers are patients with mental health difficulties.
Is your clinical hub open 24/7?
Yes, yeah, and we have. Yes. So we try to have things like mental health nurses. We would only have one per shift, but actually at the moment that seems to be all right. But certainly that's one of the things we're looking at is if we need more than one. Yeah. So everything we do is 24/7. Oh, right, okay, so this was my last scenario. So this is my favourite scenario because this was one of the first calls I ever took when I was in the service. So it was 10 o'clock on a Monday morning. It was a little boy and his nasogastric tube had fallen out and Mum called 999.
That is a complete failure on our part because actually the person who put the tube down in the first place will have taught the parents what to do in an emergency if we'd got our communication right. So.
Normally it's the home nursing team from the hospital, local hospital.
No, community children's nursing would see, I mean, they do that, so bread and butter.
Possibly, contact us if anything.
I think all of these scenarios for me are really emphasising the point, and you alluded to it just now, is about how we need an information system that links up. I work for a commissioning organisation, and we've worked really hard to make sure that our local providers and our GPs are on the same system, but wouldn't it be amazing if you just looked that person up and said, I know who your community team is, and so that it's communication between everybody, isn't it?
So if you come into our call centre, one of the things that really freaked me out when I first went in there is they have 4 screens. So they have a screen that they take information on, they have a screen for dispatch, they have a screen with map, and then they have a screen that's permanently open to Google. And basically that's what we would do if we didn't know what was in the area. We would Google where is the nearest hospital, where is the nearest pharmacy that's open, and so on and so forth. I mean, it's just, we have access obviously to other directories that we can use, but that is one of our main things we can do. If I tell you this person lived within walking distance of a local hospital, and when I spoke to them and said, has your child had their feed, so I completely blew all of the things out of the water that you're supposed to do in terms of call handling, because you're not supposed to have any clinical conversation at all. But I was just so agog, and as a colorectal nurse, I was like, do you know what, I'll just come out and put the NG back. But it's a common call we get. And I said, what kind of response were you hoping for? And she said, well, an emergency response. I said, well, with blue lights, that's what you're wanting? Yes, that's what we're wanting. So again, and in the end, we sent a taxi. And that is something that we will do on a frequent basis. Is we'll send taxis to act as transport. But that was the four scenarios that we had today. But very happy to take questions if we've got time for questions.